Esophageal disorders associated with severe vomiting. Severe vomiting and retching can lead to two distinct esophageal injuries that are frequently tested in MRCP. These conditions are often confused, yet the consequences are very different. One is usually benign and self-limiting. The other is a life-threatening surgical emergency. The key to answering MRCP questions is recognizing depth of injury, clinical severity, and systemic toxicity. The two conditions are Mallory-Weiss syndrome and Boerhaave syndrome. Let us start with Mallory-Weiss syndrome. Mallory-Weiss syndrome results from forceful or recurrent vomiting or retching that causes mucosal lacerations at the gastroesophageal junction. Importantly, this injury is partial thickness, limited to the mucosa. Patients typically present with haematemesis, often fresh blood, following episodes of vomiting. There may be associated epigastric or retrosternal discomfort, but patients are usually hemodynamically stable and systemically well. Certain risk groups are commonly tested. These include patients with alcohol misuse, those with a hiatal hernia, and patients with bulimia or recurrent retching. The clinical course is usually self-limiting. Most cases resolve spontaneously. However, if bleeding persists, upper GI endoscopy may be required for diagnosis and endoscopic hemostatic therapy. Now contrast this with Boerhaave syndrome. Boerhaave syndrome is caused by severe vomiting or retching leading to a transmural rupture of the esophagus. This is a full-thickness tear, most commonly occurring in the left posterolateral distal esophagus. This condition presents dramatically and must not be missed. Patients develop sudden, severe chest pain, often radiating to the back, following forceful vomiting. They rapidly become systemically unwell. Key clinical features include subcutaneous emphysema due to air tracking into soft tissues, mediastinitis, and signs of sepsis or shock. Vomiting may or may not be accompanied by haematemesis. The prognosis is poor if not recognized early. Boerhaave syndrome carries a high mortality and is a surgical emergency. Delay in diagnosis is the most important factor associated with death. Risk factors include excess alcohol intake, overindulgence in food, and raised intraesophageal pressure. Iatrogenic causes exist, but are less common than spontaneous rupture in classic Boerhaave syndrome. From an MRCP perspective, the distinction between these two conditions is critical. Mallory-Weiss syndrome involves a mucosal tear, presents with haematemesis, and is usually stable and self-limiting. Boerhaave syndrome involves a full-thickness rupture, presents with severe chest pain and systemic toxicity, and requires urgent surgical management. MRCP key points and exam traps. Vomiting with haematemesis and stable patient suggests Mallory-Weiss syndrome. Vomiting followed by severe chest pain and shock suggests Boerhaave syndrome. Mallory-Weiss is a mucosal tear. Boerhaave is a transmural rupture. Subcutaneous emphysema and mediastinitis are red flags for Boerhaave syndrome. Mallory-Weiss is often self-limiting. Boerhaave syndrome is a surgical emergency with high mortality.